and then we will, I guess I'll get out of here. You guys will hang around and sit over. It's not too bad in here today, though. It seems like it's actually working, so I don't want to jinx it. But so, any questions about yesterday? Now, yesterday was pretty straightforward stuff, right? As far as the very beginning material, focus on just the basics of biochemistry, the basics of lipid transport, energy, calorie count per, carbohydrate, protein, fat, what have you, and then the folds of the peritoneum. All pretty straightforward, especially with the general what does the digestive system do. So any questions, though? Anything that was unclear? All right. So start with the mouth. We talked about it as an organ, an accessory digestive organ, meaning the teeth, the tongue, all right, in order to manipulate, chew, swallow food, all right? So oral cavity or buccal cavity, I don't really hear it called buccal cavity very often, but if you see that, it's referring to the mouth or the cheeks specifically, okay? And I love these fleshy folds surrounding the opening of the mouth. Think about that, right? Okay. Frenulum. You know what is a frenulum? Frenulum are the anchoring points, right? The maxillary frenulum for the maxillary bone, and the mandibular frenulum on the mandible. Okay, just holding, anchoring the lips in place. All right. The oral vestibule is the entire mouth when you have your teeth closed. That's the oral vestibule. The actual oral cavity proper is when you have your mouth open. The inside or the lingual side of the teeth to the fauces. Or what are the fauces? Literally, if you want to look at this, the fauces is the area of the opening. I know it's probably hard to see in red, but it's essentially the area between the tonsillar arches, the actual opening of the throat. So if you can't, I'm sorry, I know maybe I need to pick a better color than red, but it's just literally the opening of the throat, okay? The palate, we have a hard and soft palate. You all, I'm sure, are tracking. The roof of the mouth, in layman's terms. The hard palate's the anterior portion. You can feel, if you run your tongue on the top of your hard palate, you can feel the transition from the hard to the soft palate. Okay? And the soft palate is contiguous with the arch that becomes the two palatine and tonsillar arches, where we find the tonsils. Okay? So hard palate becomes the soft palate back here, sort of in this area back here, and you can feel that the hard palate is formed by actual bone versus the soft palate, which becomes a lot more soft tissue and musculature. Okay, so it's still voluntary muscle. So the beginning part of the oral pharynx that helps us with the active swallow. Okay, the uvula. A little punching bag in the back of your throat, right? So everybody touch your uvula right now. See what happens. All right.
What?
Conical. It is a muscle. Actually, it is a muscle process. It helps. It has a legitimate physiologic function, and that is to close off the nasopharynx, right? So that stuff doesn't go up, right? Because it's one complete pathway. So it closes off the nasopharynx when you swallow in order to stop food from going north where it doesn't belong, right? Usually, right? Everybody's probably seen a kid blow milk through his nose at some point in their elementary school career, and then malfunctioning uvula, but still. And then at the base of the uvula, we have two main arches, palatoblassal and palatopharyngeal. All right. And here. Run that. Touch your uvula, see what happens. All right. So, tonsils. Anybody had their tonsils out? It's a lot less than when I was in school. You used to take your tonsils out like that. Mine are gone. They've been gone since I was 7. I got like one sore throat and gone. You know what I mean? Now, they have a pretty decent immunologic function that, it is more beneficial to have them than not. The main reasons we take tonsils out now are multiple repeated, I should say, evidence of cases of strep throat, like documented streptococcal pharyngitis, or the other big one would be obstructive sleep apnea. So they open up that area for the patient to breathe when they're laying down. But much fewer people have their tonsils out. So who raised their hand? Just out of curiosity. How many times did you have before they took yours out?
Wasn't it the strep? I had tonsil stones.
You have tonsil stones. That's another reason, right? You have bad breath and you have tonsil stones.
Very much.
Yeah. So they have these tonsillar concretions, right? There's these little divots in the tonsils. Sometimes food gets in there, it becomes hardened, and it contributes to halitosis. That's another reason. Anybody have them out because of just repeated strep throat? Yeah. Okay. So the tonsils that we have, what we think of, like when you open your mouth and look at your tonsils, what you think of are the palatine tonsils, right? The ones that you can see very obviously, the big ones on the sides. Okay, the lingual tonsils sort of on the back of the upper portion of the tongue, so the posterior portion of the tongue. Then the pharyngeal tonsils, adenoids, referred to as adenoids. So if you had your tonsils and your adenoids taken out, it just means you had two sets of your tonsils taken out. The lingual tonsils usually aren't touched just because they're attached to the tongue and they don't really interfere with much. And they're very small in general, okay? So, like I said, these palatine tonsils, right, these are the ones, if anybody has kids, or if you look in your, spouse or significant other's throat, they have a sore throat, and you see your tonsils are enlarged. Those are the ones you're typically looking at, all right? Lingual tonsil, like I said, is this little, I'm going to switch to yellow. Seems like today is not a good day for red. Seems just this little guy right there, and then, of course, your adenoids are farther up higher. Again, if you see this, you see where the adenoids are. What do you think enlargement of the adenoids would contribute to? Just in general, layman's terms. Nasal congestion, yeah. It would cause blockage, stuffiness. So a patient who has chronic allergies, chronic or perennial allergic rhinitis, oftentimes that'll be an indication for their adenoids to go, all right? Not necessarily having anything to do with the sore throat per se. Okay, salivary glands, we'll talk about these. I'll try to give you the easiest way to remember these, where the glands and where the ducts are, all right? So it's just, they do exactly what it says. Salivary glands produce a saliva that is put into the ducts, that is injected or released into the oral cavity, all right? Multiple different reasons for saliva. Obviously, the main one is to lubricate the food bolus and to begin digestion. So we have salivary amylase included in the saliva. We also have lingual lipase, which we'll talk about in a minute. What is a lipase? A fat enzyme, right? Something to break down fat. So that is secreted in the mouth, but it's not actually activated until the stomach. So there is no fat digestion in the mouth, although there is a lipase created in the mouth. Okay. So minor, just tiny little bits. Like these aren't the ones we usually think of. If you were thinking of salivary glands, you've probably heard of your parotid gland. You've probably heard of your submandibular glands, your sublingual gland. Those are the ones that produce the bulk of our saliva, all right? So the easiest way, and for me at least, to remember Stinson's versus Wharton's ducts, okay? Parotid glands, Stenton's ducts are superior, right? They're up, they're higher. Stinson's ducts are superior. And then we're going to talk about Wharton's ducts and the sublingual ducts, which are going to be inferior. But the easiest way is put the S's together, right? And so we have our parotid glands. You guys know where your parotid glands are. Tell me an infection of a parotid gland, anybody? Mumps. Right? Parotitis is common with mumps. You get these chipmunk cheeks, and you guys will see mumps now because we don't get vaccinated anymore for some reason, right? So, yeah, so mumps, when I was in school, we didn't even really learn about other than historic disease. Now, unfortunately, it's something you have to keep in your differential diagnosis. So, parotitis is one common presentation for mumps. Okay? And so we have the duct that comes right through here, and kind of is right in this area right here. Okay? That's where it opens up, it releases, that's where it releases its secretions, okay? There we go. Submandibular glands, these are the other main, these are Wharton's ducts. All right, there's really no good way to remember that, so just remember the S's. Stinson's are superior, and then you know where the other ones are. Okay, submandibular and sublingual are both going to be released under the tongue. The Wharton's duct are kind of right here, anterior, right under your tongue. Sort of like right there. I'll show you, obviously, on a picture. I won't just point to my own mouth, but That's where they are. Okay. If you've ever accidentally been salivating and open your mouth and saliva shot, that's where it's coming from. This Wharton duct, by the way. So, sublingual are not just a single large duct, but a series of small openings under the tongue. Okay. And so, if you look here, the sublingual, these ones right here, switch pink colors again. The sublingual right here, they're these little protrusions, right? These little guys right here. Versus here is the submandibular gland, and its duct comes up through here, like I said, anterior, just behind the lower teeth, the lower incisors. Okay? So we have Stinson's, and then we have Wharton's. Okay? What is saliva? Well, it's a bunch of stuff, but really what is the most important part of it is honestly the two most important parts of saliva are the water and the salivary amylase. Sorry, I don't know why this is off. The salivary amylase. The rest of it is, there are solutes in it. Of course, it is not just pure water, but the majority of it is just water and the salivary amylase, which begins the digestion of starch in earnest prior to deglutition swallow. Okay? So, I'm just going to tell you guys this throughout. Don't bother memorizing the contents of saliva as far as dissolved gases, various organic substances. I'm not interested in that, okay? And neither will you be when you're a clinical provider. So don't spend your time as a student trying to memorize that list. Just understand, as I'm saying, what's the most important thing. Water, salivary amylase, okay? Parotid glands. Now this is kind of important, honestly, just based off because you can have multiple pathologies of the parotid gland, or of the glands and of the ducts themselves. So you can have salivary duct stones, where an actual concretion or a stone forms in the duct, and then you have either a swelling of the parotid or a swelling of the submandibular glands. And those are painful for patients, and so it's important to know where the ducts are and what they're creating, all right? Because if you're not able to secrete a substance or release it into the oral cavity because you have a blockage or a stone, then some of the processes of the digestion may be thrown off slightly. Not a lot, but slightly, okay? So going from parotid to sublingual, we go from more serious or watery to more mucousy or thick, okay? So just as sort of a continuum. And somebody probably going to ask me why. I don't know, okay? I just don't know. Just understand that, when you get to your sublingual glands, they produce a more thick thick mucousy fluid versus the parotid, which have a lot more of the water content, okay? And let's see. This also, the other thing for saliva, excuse me, I don't know why this is off today. But the other thing for saliva is that it does begin allowing the gustatory receptors, or the taste buds, if you will, to start to open up and appreciate the chemicals that are in the food. Okay? Salivary amylase begins the digestion of sodium chloride, and then saliva is slightly acidic. Okay? Excuse me, slightly. Saliva ends up the bolus of food ends up being slightly acidic. All right, that is probably a better way to put this bottom bullet here, because generally, food that we intake is more acidic in nature. So it's bicarb and saliva does buffer slightly, but ultimately it's going into a bit of acid anyway. So it's really unimportant about the pH of saliva in general. Okay. Sjogren's syndrome is a clinical correlation here. And Sjogren's syndrome, the patient is very dry. Okay? They have dry mouth, dry eyes, okay? And then dry joints, which can lead to inflammatory arthritis. But the patient will complain of xerostomia, dry mouth, chronic dry mouth, such to the fact that their tongue starts to crack and swell. Dry eyes, which leads to sort of a chronic like scleritis, episcleritis, or conjunctivitis. And so these patients are pretty uncomfortable in general. It's an autoimmune disorder. So what does that mean, autoimmune? It means the body's attacking itself. Autoantibodies are created for some reason. And so generally, what's the treatment for autoimmune disorders? Immunosuppressant, some sort of immunosuppressant therapy, right? Now there are other, what we call symptomatic treatments, like so we can replace, tears. We can give them sialagogues to make their mouth wet. But ultimately, to treat the root cause of an autoimmune disorder, we need to buffer and slow down the immune system so those autoantibodies aren't produced. Okay. Anyway, more for that later. But you can see this patient, chronically dry eyes, chronically cracked, dry tongue, and so there really is no replacement for saliva. So what we give is a sialagogue, something that will stimulate saliva production. And generally, what do we use for those? Sour things like lemon drops are very common, right? So sour candies, things like that really stimulate. Maybe the citric acid component, I'm not really sure, but just stimulates. Like you put like a Sour Patch Kid or a Warhead, your mouth waters really bad. That's what we use to help these patients sort of keep their mouth chronically more moist. And of course, they need to do their part drinking tons and tons and tons of water. Okay. All right, the process of salivation. Any questions so far? Am I going too fast or are we good? It's pretty straight. Okay. So autonomic nervous system. This is kind of gross when you think about it, in my opinion. 1 liter to 1.5 liters of saliva a day. It's kind of gross if you think about it. It's gross to me anyway. I don't know. What is it? So that's a lot. Parasympathetic process. Why? Feed or breathe. Exactly. Right? Rest and digest. Exactly. Right? And then, so what do you think happens with parasympathetic stimulation is overridden by sympathetic stimulation? Dry mouth. Exactly. Which is why you get a dry mouth when on test day, when everything's firing and you can't take it, and you're like, right? Exactly. Dry mouth. So there you go. Xerostomia. What contributes further to dry mouth? What helps us conserve water in the body? Antidiuretic hormone. Not only does it have effect on sudiferous glands, sweat glands, it has effect on salivary glands. We're trying to keep the water in. Okay? Keep the water in. Chemicals in the food stimulate. I told you that already. Okay? And then, again, this one, not super important as far as the nerves that return taste sensation, but just so you know. Okay? And ultimately, it becomes important when? When do you think? Clinically. When a patient can't taste, right? When a patient has dysgeusia, they can't taste. Right? There are other reasons for not being able to taste other than COVID. So if we have a neural issue, then maybe we can solve it. But in general, not really that important. Okay. And then, anybody know Pavlov's dog? Right? Ring a bell, the dog salivates, right? You torture an animal and it salivates, unfortunately. So the thought of food can stimulate. So think about food right now, and you'll stimulate saliva. Everybody knows. Weird. All right. Any questions about saliva? It's a lot.
Regarding the ducts, you said you can develop stones. Is that just like hypercalcemia or something? Like what would cause stones in those ducts?
Some kind of buildup, some kind of. What are they actually? What are the concretions actually made of? Sometimes, if you have a patient who has like an obstruction for some reason, you can get the buildup of the actual solutes of the saliva can cause it. I don't really know what the actual makeup is. I've never collected one like a kidney stone. Right? Sometimes it's not even a physical stone. It's just a swelling or an obstruction. So I don't really know what they're made of.
It's not common though, like out in the.
It's common. It's just like for a kidney stone, right? If we have a kidney stone, I'll have a patient pee in a filter and catch it and we'll see what it's all about. For a salivary duct stone, I've never done that, and I don't know anybody who has, so I don't really know the chemical composition, but we can find out. Oh, why not? Go for it, man. Yeah. Anyway, any other questions? All right, tongue. There's a picture of it. Accessory digestive organ, not just for, not just for tasting, but also probably almost more importantly than tasting is the manipulation of the food bolus, moving it around so that it can be adequately chewed and then swallowed, right? Tongue has a big portion moving the food bolus back into the oral pharynx so that we can swallow, okay? The lingual frenulum and the labial frenulum. So the lingual frenulum is on the tongue. So anything we talk about lingual, we're referring to the tongue in general, and labial, of course, referring to lips in general. So we have the labial frenulum, holding that down, and the lingual frenulum. We're going to discuss those. But anybody heard of somebody being tongue-tied? Ankylosing. So if you're short lingual frenulum, usually genetic, the patient cannot move their tongue around sufficiently. It's kind of tied down from a short lingual frenulum, and so they have difficulty with speech, with swallowing, so on and so forth. And so what do? A frenulotomy, and open it up and lengthen it out. Okay? So you can see that person would have difficulty with phonation or speech, and then just pop it open, everything's good to go. Okay?
I have a question.
Yeah.
In that, I guess disorder.
Do I?
Are there like nerve connections and vasculature?
In the lingual frenulum?
Yes.
Yeah. I mean, it's tissue, sure. But I mean, when you cut it open and cauterize it, it's fine. I mean, it's not something that you do without anesthesia. Like you give that patient like a local anesthetic and then you just make the snip. And then again, it's not huge blood vessels. I mean, the mouth, the face, the head generally do bleed a lot because of tons of capillaries, tons of blood flow. But you just cauterize it and the patient's good to go. Yeah. In the tongue, we have these lingual glands, von Ebner's glands, that secrete lingual lipase. Now, the important thing again is that lingual lipase, again, it's secreted in the mouth. It's made by the tongue, but it's not activated until the pH drops in the stomach. So there is no fat digestion that occurs in the mouth, all right? There is carbohydrate digestion, but not fat. Then we have our taste buds, our papilla. Not all of the papilla have taste buds. I take that back. I should make that correction. So we have papilla. Some are just tactile, right? Proprioception, helping us to move and chew the bolus around. Some have taste buds to actually help us with tasting, right? So the two that have taste buds. Now here's another point for you. I don't care how many taste buds each one has, so do not spend mental energy on that. Just understand that these two do have taste buds and the other two don't. So villate or circumvillate, they form a V, so that one's easy to remember. In fungiform, what does it sound like? Mushroom, exactly. That's what they kind of look like, okay? Foliate and filiform, no taste buds, more for tactile, all right? Foliate are kind of these little ridges on the side of the tongue, and filiform are kind of everywhere. Right? Mostly just tactile, proprioceptive. Understanding we need to manipulate the bolus around so our different types of teeth can do their different jobs, and then we can propel back and swallow, okay? So if you look here, circumvallate or vallate are these V's. The foliate, like I said, just tiny little ridges on both sides. It just shows it on one here, but they're on both sides of the tongue. Fungiform and filiform are kind of everywhere. Fungiform are scattered throughout, but they have taste receptors. Okay? Any questions? I wish it was more interesting, but this is when we're talking about the tongue. Yes.
Is there significance about the foliate, just about why they generate taste buds as like kids grow? Why do they? Is there something that they're specifically tasting as their kids that they don't need to taste anymore?
No, I don't know. I don't know the answer to that question. I've never bothered with it, but there's another ChatGPT question for you. Right. Okay, thank you. After class, he'll have the real lecture where he fixes all my mistakes. Okay.
Just recording right now.
Yeah, just.
GPT.
All right. Mechanical digestion, aka chewing, to begin with, right? We're talking about the mouth here. That's one of the grossest pictures I've ever seen, but I gotta leave it in there. All right. And I'd love to know what the hell that guy is eating.
Looks like cock.
Is it broccoli?
No, it looks like
I don't know, just, huh?
looks like cock. That
Whatever it is.
amphetamine type of thing, like
Oh, yeah. Maybe it is. I mean, look at the
like
dude.
East Africa.
Yeah, so.
Except he doesn't look East African.
So we are literally, mechanical digestion, literally the physical chewing of the food, the breaking apart of the molecules, beginning to crush it into smaller pieces to create increased surface area for chemical digestion then to sort of take over, right? If you just throw, like it's, you guys all know surface area, right? If you take an ice cube and you put an ice cube on the table, it takes a while to melt. If you take that ice cube and you crush it into tiny little pieces, it melts a lot faster. So the surface area that's created helps more space for the chemicals like salivary amylase and so on and so forth, the other things we're going to be talking about, to have spots to begin their process of chemical digestion. All right? So I think this has become pretty clear at this point. All right? Salivary amylase from the saliva begins carbohydrate digestion. And then what really picks it up, we'll find out later, is pancreatic amylase, which is the majority player in carbohydrate digestion and absorption. And then again, lingual lipase secreted by the von Ebner's glands, but not activated until it hits the stomach, because it needs to be activated by the acid. Any questions? So, pharynx, we got the nasopharynx, oropharynx, and hypopharynx. All right. Most of the tissues in the pharynx are skeletal muscle, right? So voluntary. Nasopharynx doesn't have a real role in digestion, right? The uvula closes it off because it's really just a breath passageway. Okay. Oropharynx, digestion and respiration, of course, in the hypopharynx. Same. And so you've got two different names for this one. We call that out before I show you. Oropharynx or laryngopharynx. Right? The hypopharynx, oropharynx, then the hypopharynx or / laryngopharynx. So, food's in the mouth, goes to the back of the throat, that's the hypo or laryngopharynx, okay? All right, now let's get into some more interesting stuff, at least to me. Any questions about that? Mouth, tongue, saliva, gee whiz, right? But you got it? Any questions? All right, so we'll talk about now the real digestive passageway. The esophagus, we've already discussed. The top portion of it, the top third, if you will, is skeletal muscle, right? And why is that important? Voluntary swallowing, so we can swallow food. Then we have a transition part. So that middle part is a mix of smooth and skeletal muscle, and then we have the bottom part is smooth muscle, okay? Posterior to the trachea, why? Give me a reason. Because this has cartilage rings in it. It's not collapsible, right? The esophagus is collapsible. If the esophagus was in front, it'd be really hard to do anything, right? Okay? If you have, the diaphragm goes, where are we at here? I cannot find this little stupid thing today. So, yeah, close enough. So, the diaphragm is pierced several different places at places called hiatuses. I think we've talked about some. The aortic hiatus, right? We've talked about hiatuses that go through. What pierces, how the esophagus makes it through is called the esophageal hiatus, right? So the diaphragmatic, so that's where the esophagus passes through the diaphragm and then the stomach's underneath. Has anybody ever heard of a hiatal hernia? So hiatus, right? So if a portion of the stomach comes up through that hole, which is that diaphragmatic hiatus, that's called a hiatal hernia. It's a herniation of the portion of the stomach superior through the diaphragmatic hiatus. Okay? So right here, this is that area, that diaphragmatic hiatus I'm talking about. So what happens is, usually, either this portion of the stomach is pulled superior, or sometimes this whole portion over here is pulled up superior, depending on the size of the defect. Okay? Physiologically, anatomically and physiologically, what is the diaphragm? Or what is the esophagus? It's a food tube. Yeah. It's the food, it connects the mouth hole to the stomach hole. Right? It doesn't really have a whole lot of function, right? It secretes mucus to help it protect itself, to help facilitate the bolus passage through so it doesn't get stuck. But other than that, it doesn't have a whole lot of true function. It doesn't secrete anything as far as products of digestion, right? Just mucus lining the cells. Superficial surface, we've done this already. It's the same. Adventitia muscularis, submucosa, and then mucosa, right? And so the mucosa is 3 layers. This is the big one that I was talking about yesterday. I was talking about the different sort of histologies. Non-keratinized stratified squamous epithelium, right? So layers upon layers of cells. Helps to protect the esophagus and the very, sort of fragile mucosa from the abrasive material that we swallow, right? And even though the bolus is lubricated with saliva, lubricated with the mucus that the esophageal cells create, it's still fairly abrasive, right? It's still a generally solid food component. Also, think about the other things. Think about swallowing pills and other solid objects like that. This helps protect the esophagus from that, okay? Each end of the esophagus we have sphincters, right? Not really true sphincters, but sort of anatomic sphincters. Skeletal muscle at the top, smooth muscle at the bottom, right? So again, skeletal muscle at the top. Why? Because we can swallow voluntarily. We can move the bolus of food into the esophagus through conscious thought. We have no control over the lower esophageal sphincter, okay? This here is kind of important. We do have a slide on GERD, which I'll explain in a little bit. But when you guys get out there and you start seeing patients who have chronic reflux, there is a whole list of foods that you want them to avoid, substances you want them to avoid, because they have a direct effect to relax the lower esophageal sphincter. So the whole mechanism of GERD is that stuff is going north, right? Because that lower esophageal sphincter isn't closing adequately. So patients who smoke or use vape or use any kind of nicotine product, nicotine relaxes the lower esophageal sphincter. Coffee, caffeine, peppermint, right? So all the stuff that patients will just totally love to give up, right? So this is what I was saying, therapeutic lifestyle choices, therapeutic lifestyle changes, probably the hardest treatment to get patients to actually do, right? So you have here, lower esophageal sphincter right, where the esophagus meets the stomach, and then the upper esophageal sphincter is this tiny little narrowing right here, okay? Upper esophageal sphincter, not usually a culprit in a lot of things, not usually. All right, there are multiple, and I'm not going to, remind me to stay on topic and not go down pathology too much, but there are several different pathologies that can actually form in the trachea. You can get what's called a diverticulum. You guys know what a diverticulum is? It's an outpouching, right? Like a goose egg on a tire, right? So if that develops in the esophagus, then you can have chronic swallowing problems, chronic digestive problems, chronic irritation, halitosis, so on and so forth. But usually the upper esophageal sphincter is not much of a culprit in pathologies that you'll encounter clinically. LES, very different. LES, very much so. Okay? Any questions? You guys okay? It's too much? You heard? All right. So, deglutition, aka swallowing. But it sounds more important, more impressive to patients when you say deglutition. You have issues with deglutition? What do you mean? I forgot you didn't go to medical school. Swallowing. Sorry. You like to be, infuse your patient care with sarcasm as often as possible. Right? So, voluntary stage, right? What is facilitated by that? What I mean, I know we're going to talk about it, but what do you let's just go through it. What do you think facilitates the voluntary stage of swallowing?
Your tongue.
Your tongue, yes, helps move it up and back, right? And the skeletal muscle, right? Then the pharyngeal stage, that initial part of of that bolus being in the back of the throat, still in skeletal muscle, moving it down, and then the esophageal phase. What does that mean? That means when the food goes from the mouth hole to the stomach hole. Okay? Right, here we go. See? You guys figured it out. The bolus is in the back of the oral cavity, moves back to the oral pharynx, pushes up and back. That's what the tongue helps us do, okay? You know what else the lingual frenulum does? It keeps you from swallowing your tongue. You can't actually swallow your tongue, okay? The pharyngeal stage, this is a very long slide to say that the food now is in the back of the pharynx, the uvula swings up, and the food goes down. That is really it, right? What else happens that's important, right? Anybody familiar with the epiglottis, right? So we have a flap that closes the nasopharynx, we have a flap that closes the trachea, and the food goes where it's supposed to go. Usually, right, okay? And then the esophageal phase, now it's in the food tube and it's going down to the stomach. This is gee whiz knowledge, just so you know. Gee whiz knowledge for now. Let me just tell you this. If you have a patient who has dysphagia, which is difficulty swallowing, or odynophagia, which is painful swallowing, you can do esophageal motility studies that then these numbers become important. To you now, I don't care. All right, we're not going to be timing patients swallowing, and neither are you, unless you work in GI. Okay, so stick to primary care. Just understand it should go fairly rapidly from here to here. All right, and then there's a picture for all of you visual people. Okay. What time did I start? It's not break time, is it? Okay. You guys are hanging in there. I appreciate it. All right. So, GERD, gastroesophageal reflux disease. Not ironically named. That's exactly what it is. Okay? That lower esophageal sphincter is supposed to remain competent. Close the bottom portion of the esophagus so that acidic contents of the stomach, whether they be food or just acid, stay where they're supposed to stay. Right? There is squamous epithelium, right? Stratified squamous epithelium that lines the esophagus. We talked about that, correct? That stratified squamous epithelium is not histologically, anatomically, physiologically meant to be protective from that acidic content of the gut, of the stomach, right? So if you have those acidic contents going north, superior, what do you think happens? It damages the tissue. It burns, heartburn, right? It's not supposed to be there. Over the course of a long enough period of time, what do you think happens? Not scarring, even worse. You got, okay. All good choices. Have you heard of the term dysplasia, metaplasia? Okay, so metaplasia is a changing of one tissue into another. So what happens is the cuboidal epithelium, the cuboidal cells that are in the stomach that are protective of the gut, are protective against that acidic content, they start to migrate north. So when you have metaplasia, aka cellular change, what does that sound like it could progress to if it goes unchecked long enough? Dysplasia. Cancer, exactly. So the real prolonged risk of GERD is the development of something called Barrett's esophagitis and then esophageal cancer. Okay? Because anytime you have unchecked cellular change, there is a potential for it to transform from a normal, healthy cuboidal cell into a dysplastic cell. Right? And then what did I say is the real problem with cancers within this tube? They don't necessarily manifest right away, right? And here's the real risk. What happens, just you got to put your thinking caps on now. This is a real prelude to GI. What do you think happens to the patient's symptoms of heartburn and pain if that lower portion of the esophagus starts to remodel with the cells that are in the stomach? Their symptoms start to go down, which what does that signal to your patient? I'm getting better, so I don't need to go to the doctor or the PA. And then what do they have growing in their stomach? Cancer. Okay? So even things potentially as seemingly innocuous as reflux, heartburn, have long-term negative consequences. So that's why you have to take care of it and recognize those long-term consequences, right? This is something that a patient, they're going to go to the store and buy Tums, buy Tagamet, buy Pepsid. You know, they can get PPIs, proton pump inhibitors, over the counter now. So if your patient complains to you of symptoms of heartburn, remember this and tell them that we need to make sure that's under control. Okay? And more to follow in your junior semester. Okay? So, this, without going too much more, this squamocolumnar, what the hell? This is called the Z line. Right? You don't need to know that for this class. It's called the Z line. If we see that Z line go north, that's evidence of Barrett's. Okay? So, any questions on the esophagus? Okay, friends. Yes. Okay, so that's a great question. So you try to control it symptomatically with telling your patients not to eat things that will relax it further, right? You try to treat it symptomatically with PPIs, proton pump inhibitors. Proton pump inhibitor, what's a proton? What's another word for a proton medically? Acid, right? So we try to suppress the amount of acid that the stomach creates to reduce the burden of what might be going north. We tell patients not to lay down after they eat because gravity is not their friend, right? Gravity is their friend, I should say. If that doesn't work, then we take surgical steps, right? So there's surgical steps you can take. We actually take the top portion of the stomach and wrap it around, and that way when the stomach contracts after they've eaten, it helps close off. It acts as a buttress to that. So there's a whole spectrum of what we can do about it. The big portion over here that nobody wants to do is help themselves. You know what I mean? But yeah. Does that answer your question? Okay. All right. Anybody else? Do you want to take a break before we do stomach? We're getting pretty close, but I think we have enough slides where you might want to take a bathroom break if you need it. So you guys want to? All right, go ahead.
I'm actually, I've never even thought of it. Pop that thing out. Yeah.
That's what I'll be doing when I get back. Let it sit in the fridge for a few hours. You get home and you'll probably get home until like 3:30. We have lab breaks. Been running on like 7
Mine went up by like $50.
All of those things.
It went from 120 to 197.
I just do
No, it's just a whole bunch of road like all around.
It's just not late after you lay
Yeah.
down. So if you put it think about it.
I mean, nothing's finished like I want now. We're just kind of waiting to hear back from you. So that would be like higher than that. They'll look at you with the
It's not like a full regurgitation.
yeah.
So again, it's not an anatomic. It's just muscular. Yeah, exactly. For any number of reasons, not even for your own patient, what is the prime motive of their Because again, it's not a
What? Oh, yeah.
it's not a physical closure. Relaxes or too big. It's the same thing, it's like, it depends on what. So regardless if you finish the center or not. And so yeah, the biggest thing too, when they have real peppers, very little of coming from that first pops up, usually that happens.
Stuff. Those two. Yeah, and then wraps it with bacon. Oh. Smoke it. Look like donuts. Delicious, yummy donuts.
But when you get to there are some. Have you ever heard of cop? You ever heard of yes, yeah. Oh god, that's what it looked like. Big old lime green. I don't know. Some of the stuff I think makes just Terry like I taught this one. I taught this one to the seniors actually when they were freshmen. She was out and like don't get me wrong, these are all nice. I leave some of her shit in because some of these little nuggets that she threw in there. Yeah, but you can't. And I don't know if she intended them to be funny, by the way. It's like golf ball. Size like freaking baseballs. Did you it was just like we're just selling that and then everybody was on as it's just you want more of it. Just freaking that's what wrecked. My first experience watching like we're going to dinner one night and there's a guy outside in front of me. Freaking drooling, green drool with this stuff just gone. And just stands. That's the main thing that they're you're having more money. They always say don't go out on Thursdays when they get the shit in where they grow it on it. It's like in Somalia or like certain stuff that they sell there. The good things. We observe it. We observe it.
it's not all one cumulative, it's each one.
Be out by the lake fishing.
I don't remember if
Yeah, like
But you can find it. There's tons of
All right, everybody ready? All right, questions? Any questions? Okay. The stomach, and then we'll be done. So, stomach has a large part to play still in mechanical and obviously chemical digestion. All right. It is very expansile, which is one of the reasons somebody asked me, like, how does the LES end up maybe opening? If you overfill your stomach, the LES isn't a physical closure. It's not a flap of tissue or anything like that. If you overfill your stomach, you can stretch out the LES. Right? Everybody after Thanksgiving, if you had too much Thanksgiving of that food, baby, and then you lay down, your LES is going to be open. All right, a little bit. So we'll talk about the different sections of it. The cardia, the main section, cardia, fundus, and then the body. And then we have sort of the pyloric area, which includes the antrum, the canal, and the pyloric sphincter as it empties into the duodenum. Okay. So the cardia is the superior portion, right? So up here, this is the portion, the cardia, that oftentimes, most commonly in that hiatal hernia gets pulled through. If a patient has a more serious defect. Sometimes the fundus can get pulled through. And then back to your question you asked, how do you close, like that operation I was talking about, it's called a fundoplication. So fundus is wrapped around the LES, the lower portion of the esophagus, the fundus, fundoplication. What does plica mean, anybody? Sort of like a fold, okay, a fold of tissue. So we fold it around. Then we swallow food. What happens as mechanical digestion starts? What happens to the stomach? It contracts, essentially. And so as it contracts, it squeezes off and helps keep that competent, okay? So that's the fundus, the round upper portion of the body, sort of the major portion. And then the pyloric area, the antrum. But what's an antrum? Like an antechamber, right? The beginning portion of the beginning portion. The canal, the pyloric canal, and then the pyloric sphincter. The pyloric sphincter represents the end of the stomach and then the beginning of the small intestine, the duodenum. Superficial layer, now we have histology becoming more important in the stomach because now we're starting digestion and the production of digestive products in earnest, right? We are secreting stuff that we need in order to digest food versus just mucus or just saliva, right? So these are the same areas, serosa, right? We talked about some have an adventitia, some have a serosa, the stomach has a serosa. And then the muscularis. What does the myenteric plexus control again? Movement, right? Yes, exactly. Movement. And then what is the submucosal plexus? Secretions, right? Secretions. Put those two together in your brains, right? So we're going to talk about all of these cells now, one by one, because they have independent functions, and they're important about what they create. So the mucosal layer contains these functional areas called gastric pits, right? Deep pits, and they're exactly what they sound like. Right? The pits have chief cells, parietal cells, and enteroendocrine cells in them, right? The surface area, before we get to that, has these goblet cells, which secrete mucus. So let's talk about all these different cells. And there are some ways, there's some memory mnemonics you can use. I'll tell you when I can find it, but a lot of times this is just creating a chart and remembering what cells create what. Okay, y'all, I wish there was an easier way. Some of anatomy and physiology is just memorization. This is one of those things. All right. So chief cells make pepsinogen. What does that sound like it does? That's right. It breaks down peptides, exactly. All right. So chief cells stimulated by hydrochloric acid, right? And I know we haven't got there yet, but what do you think stimulates hydrochloric acid production? Food entering the stomach, food entering, recognition. We have to start making stuff to digest this. So pepsinogen is stimulated by hydrochloric acid, okay? And I think I told you yesterday that protein digestion begins the major protein digestion begins in the stomach, and that's how it starts, okay? Now we have parietal cells. They secrete hydrochloric acid, right? Intrinsic factor and bicarbonate. Sounds weird. Why should we stimulate bicarbonate secretion? Ultimately to help buffer, right? The acid belongs in the stomach. The food will buffer it slightly, but we need to buffer it slightly even more. Where do we get another big push of bicarbs? Anybody remember? Pancreas. Yeah. Pancreas, right? So the hydrochloric acid, it basically deaminates salivary amylase. So we stop the carbohydrate digestion that we began when we get there. But it activates the lingual lipase. Remember, no fat digestion in the mouth. Fat digestion beginning in the stomach because of the activation of lingual lipase. All right? and then activates the pepsinogen we just talked about. Intrinsic factor. Anybody familiar with the term pernicious anemia? So pernicious anemia is a patient who doesn't make or can't utilize intrinsic factor, has autoantibodies to intrinsic factor. Intrinsic factor is crucial to the digestion and absorption of vitamin B12. Okay? So that's made in the stomach. So if a patient has a partial gastrectomy, or full gastrectomy, or some kind of gastric bypass, what could they be at risk of? Pernicious anemia, right? B12 deficiency. Okay, there you go. G cells, gastro, that one's pretty easy. Okay. Secretes the gastrin, okay? And this, if you take a look here, acid production, histamine release, and then repair. So gastrin sort of helps the stomach do what it's supposed to do, helps repair the stomach. Histamine, right? Release from the stomach. So we have an H2 blocker, right? Those are other things. We stimulate acid production with histamine. Histamine blockers, H2 blockers like Tagamet, Zantac, Pepsid. This is why they work, sort of, for GERD patients. They're not as efficacious as PPIs, but they work. Okay? There's a picture for you, if you like. Enteroendocrine D cells and enterochromaffin cells. Yeah. So histamine, we've already talked about that one before. And this one, D cells. Somatostatin. Another place it's made. Okay. So it inhibits gastrin release. So it's a negative feedback loop for gastrin. What does the D in D cells stand for? I don't know. All right. The pH of the stomach can go from about 5 down to about 2 or lower, depending on what we put into the stomach. All right. So when we get down to these lower pHs, more acidic, that's when a lot of these zymogens are stimulated, meaning the precursors of the actual triggering of the mechanism of the enzyme to start digestion, like pepsinogen. Goblet cells. Now these are, the easiest way I remember these is there's goblets of mucus. These are the cells that produce the mucus that help protect the lining of the stomach from all of that stuff. Okay. And so, let me see here. If this is this is why we need it, right? If we don't have the mucus covering all of these other cells, essentially what's going to start happening is the stomach will digest itself or erode away. What is another name for that? Ulcer, right? Peptic ulcer disease. If you've heard of peptic ulcer disease. So deficiency in that, a break in that area is peptic ulcer disease. Or worse, right? So that's a peptic ulcer right here. This little erosion. And then what's the risk of that erosion? Huh? No, H. pylori can lead to that. The real risk of that erosion is eroding down into a vascular bed or worse all the way through. Right? So, bleeding or actual perforation. And peptic ulcer disease can proceed to that quite often. Sometimes your patient's initial complaint with peptic ulcer disease will be hematemesis or coffee ground emesis. Right? Hematemesis, bright red bleeding, generally coffee ground emesis. Anybody know why it would be coffee ground emesis? Because the blood is sort of bleeding in the stomach, partially digested. It's an irritant and a cathartic, meaning sometimes they'll have diarrhea, other times they'll vomit it, and it looks like coffee grounds because it's partially digested, the hemoglobin content. Right? Propulsion and retropulsion, essentially, if you want to think about this like a washing machine, okay, it's smushing it forward, smushing it back, smushing it forward until it's sufficiently smushed. to go through in through the pyloric sphincter and into the duodenum. Okay? And again, what is the main point of the swishing? Surface area. Increasing surface area so that all of the rest of the stuff, because yeah, there's a lot of stuff made in the stomach and protein digestion starts and that's all well and good. But where does the real digestion and absorption happen in general? In the small intestine, right? So it's prepping that bolus. It becomes chyme. Did we see that? Did I skip over that? So when it hits the stomach and starts to become liquid that then makes its way into the duodenum is called chyme, chyme. It's in the slide somewhere. Okay? That has a significantly larger surface area so that now the pancreatic juice, the pancreatic enzymes can do their thing and have more area to be productive so that digestion can occur rapidly, right? If a solid food bolus just made its way all the way through, it would have a hard time actually digesting. All that would come into contact with the enzymes would be what's on the outside, right? Does that make sense? Okay. And then pepsin, we talk about chemical digestion. So mechanical digestion is the propulsion to retropulsion, the smushing of the food. And then the pepsin is really what happens that's produced in the stomach as far as digestion. Other digestion processes that happen in the stomach are what? Anybody remember? The activation of what product? Lingual lipase, right? Yeah. Lingual lipase, again, a minimal contributor to lipase digestion or lipid digestion. Pancreatic lipase is the major player in that one too. So again, this is a prelude to getting it into the duodenum where it's going to come in contact with the sphincter of Odi, which is where the hepatobiliary pancreatic stuff comes into play, all right? And there you go, lipase. Digestion in the stomach, very little of any absorption in the stomach. Okay, it's not what it's meant to do. All right? Not what it's meant to do. One thing that can irritate direct gastritis is this little guy right here. So alcoholic gastritis, sometimes it's just from the physical contact of the alcohol with the stomach. The patient can get a gastritis. What is the itis? Inflammation. Inflammation of the lining of the stomach, right? It's irritating to that, sometimes if it's in there long enough. Okay? And then what else? What if I told you that what stimulates the production of mucus is a prostaglandin? What is a prostaglandin? Does anybody remember? Some kind of inflammatory marker kind of thing, right? And prostaglandins make the gastric mucus. What blocks prostaglandin? NSAID. So, what can cause a long-term chronic gastritis? NSAIDs, 800 milligrams ibuprofen, right? 800 milligram ibuprofen, especially 800 milligram ibuprofen, or indomethacin, right? Naproxen, Daypro, aspirin, you name it. Even Celebrex, which is still out there. Celebrex is not uniquely, it's unique in it's a COX-2 inhibitor, but it's not immune to the side effects, all right? So again, that's why we talk about if we put a patient on a NSAID for a long period of time, we might add a PPI with that to help protect their stomach if they need to be on it. It's a risk-benefit. Do they need the PPI? Or do they need the NSAID, or can we put them on something else like Tylenol? Anyway, that's why NSAIDs cause that problem, because they block that mucus production, which reduces the protective layer, which then induces chemical contents coming in contact with this stomach cell, with this lining of the stomach that's not supposed to. All right, that's one of the major reasons why we have NSAID-related gastritis. Make sense? Okay. Eructation, aka perfect. All right, so we talk about gas-producing foods. When you get to GI, you'll talk about something called FODMAPs. It's an acronym for certain types of long-chain polysaccharides that cause or lead to eruption, they lead to burping, excessive gas production. Beans are on there, right? Okay. You know what else? Cucumbers are on there. Anybody else burp when they eat cucumber? No? Maybe I'm just weird. That's why I don't eat cucumbers. All right. Anyway, so it's really not a problem unless it becomes physically disruptive to the patient. If they have gas that forms it becomes painful, bloating and gas. But other than that, it's just a normal venting of gas, so to speak. Any questions? You guys look just bleed. What the hell's wrong with you? All right, come on. Huh? Parietal cells. Yeah. What do chief cells make? Carcinogen? I know you don't remember. Enterochromatin cells make histamine. What do G cells make? Give me that one. Gastrin. There you go. All right. All right. Parotid glands. Stinsons. Parotid superior. Right? True or false? Holy shit. False. All right. No. All right, that's it. Everybody go away. Have a great day. Enjoy cleanse skills. Hope it's cooler in the PE lab.